Hello everybody and welcome at the European Heart Rhythm Association meeting 2019 in Lisbon. It's a wonderful event, really great success of people attending with really full of innovation and new stuff. It is my pleasure to present you the CRT highlights. We had many important contributions, several late-breaking trials, and I'd like to summarize what I think are really the most important points of these CRT sessions. So first, we have a very nice presentation by the ESC and EHRA survey. Is a very large study cohort, more than 10,000 patients included, and one of the presentations was focusing specifically on atrial fibrillation. As we know, atrial fibrillation is a pretty common disease. About 20 to 30% of the people may have AF, but in the EHRA and ESC survey, so it was much larger number of patients who have had AF. So essentially it was approximate 40%. And this is the very first time that we have seen this very high number of patients. The interesting part of the survey was that the patients with a paroxysmal, persistent and permanent AF was different distributed according to the New York Heart Class Association. So essentially, many more people had a New York Heart Class 1 and had the paroxysmal, whereas Class 4 patients had significantly more permanent AF. Also, the distribution between CRTP and CRTD was unequal. Essentially, more patients with atrial fibrillation had a CRTP. Certainly, because a part of this is related to the fact that they are aged people, have many more comorbidities, and so this was one of the reasons why probably investigators decided for a CRTP. Another interesting observation from this registry is the fact that the mean ejection fraction between the two groups was not particularly different, but again the implantation rate seems to be slightly different. In any case, this indicates that we really need now very large prospectively conducted trial in atrial fibrillation patients, because we don't have any so far. So another interesting study was the Bruce control study. Essentially is a strategy between vitamin K and vitamin K therapy at the time of the ICD or CRT or pacemaker implantation compared to bridge to another therapy. Within this study, there was a subgroup of patients, about 280 patients, who had at the time of the vitamin K also an antiplatelet therapy. And the investigator investigated whether those patients who have been on antiplatelet therapy had a same event rate as those in no antiplatelet group. And indeed, in the no antiplatelet group, there was a much lower event rate compared to the one who continued the antiplatelet therapy. Interesting was also the observation that essentially potentially inappropriate antiplatelet therapy and potentially interruptible antiplatelet therapy was a substantial proportion of patients, about 30% of those cases. So one other study who captured my attention is, of course, the His bundle pacing. In particular, we had a group of patients, or we had a very nice study from UK showing in a very elegant way how activation, 3D activation of a ventricle is during His bundle pacing compared to traditional CRT. And we also had a hemodynamic measurement, and there you can really nicely see that His bundle pacing really provides a much synchronous, more physiological activation compared to CRT, and as a result of this one, also the hemodynamic function, so the systolic blood pressure was much higher in the group of His bundle pacing, confirming again that probably His bundle may become one of the alternative, a very, very good alternative to traditional CRT. So then we had three major studies, three major late-breaking trials, all addressing the point whether the mechanical target of a CRT may be as good as eventually either anatomical driven or the electrical driven implantation. So essentially of these three trials, two showed that in both cases the mechanical or the targeting of a mechanical dysynchrony is not superior to an anatomical driven. Whereas the study indicating the comparison between electrical versus mechanical match showed that a slightly higher trend for the electrical therapy compared to the mechanical, so the targeting of a mechanical position. So altogether, this study shows in any case that when you are able to match a late electrical or a late mechanical, the outcome of the patients is significantly higher compared to the rest. And finally, we had a very interesting contribution by, again, UK is a very, very large registry on 50,000 patients on CRT. This was conducted by Dr. Leva, and he showed essentially that and he compared the expected survival in the group of patients compared to the CRT and CRTP. He showed that really the CRT and CRTP is bringing the survival of the patients much higher or closer to the expected survival rate, where OVH, you see that you have, of course, a much larger difference, indicating that the time of implantation to CRT and the subsequent effect of a therapy is reducing over time and with the age of patients. Another important contribution from this registry was the fact that women certainly benefit most from the CRT. So another confirmation that women, which in general are less frequently referred for CRT, they do derive the best benefit. And in particular, if women has really no comorbidity, after CRT, the expectance rate is as high as the one that who never been treated, for example, for other causes of heart failure. So I think that is a very, very important message. And finally, there was a very interesting contribution about the effect of photon therapy on devices. So this is an in vitro study, but indicated or showed that even if you have a patients who have to undergo a radiotherapy, this can be safely done in patients with seeds because there is no electromechanical interference, so it can be safely scanned and safely treated seeds patients. And with that, I thank you very much for your attention, and bye-bye from Lisbon.